This morning, the World Health Organization declared a global health emergency. An Ebola outbreak in the Democratic Republic of the Congo and Uganda, caused by a strain called Bundibugyo, has been classified as a public health emergency of international concern. I'm Dr. Fabíola Tiburcio, dermatologist and co-founder of No Infection Consulting and Education. This is Infectious Diseases in Focus. Today I want to explain exactly what is happening, why this particular outbreak is so concerning. Let me start with what makes this outbreak different from the Ebola outbreaks most people have heard about. When people think of Ebola, they usually think of the Zaire strain, the one responsible for the catastrophic 2014 West Africa epidemic and the large DRC outbreak from 2018 to 2020. That strain has an approved vaccine. It has approved treatments. Healthcare workers responding to it have tools. The Bundibugyo strain is different. It has only been documented twice before in history. In Uganda in 2007 and briefly in 2012. It is rare. And because it is rare, there is no approved vaccine against it. There are no approved specific treatments. The only licensed Ebola vaccine and therapeutics are all specific to the Zaire species. They do not work against Bundibugyo. This is what makes today's declaration so significant. They do not work against Bundibugyo. This is what makes today's declaration so significant. We are facing an Ebola outbreak with no vaccine and no approved treatment. Early supportive care is what saves lives. And getting patients to care quickly is everything. Here is the timeline of how this outbreak unfolded and why the WHO is concerned about how long it went undetected. On April 24th, the first known case, a health worker in Bunia, in Ituri province of the DRC, developed fever, hemorrhage, and vomiting. They died within days. The outbreak was not flagged to WHO until May 5th through social media reports of a high mortality unknown illness, including 4 more health workers who had died within 4 days of each other. By the time WHO was alerted, 50 people had already died. The virus had been circulating silently for weeks in a region with active armed conflict, limited healthcare access, and high population mobility. A second unrelated confirmed case appeared in Kampala on May 16th. As of today, May 17th, 246 suspected cases, 88 deaths. A second unrelated confirmed case appeared in Kampala on May 16th. As of today, May 17th, 246 suspected cases, 88 deaths. And 8 laboratory confirmed cases with a positivity rate of 62% among samples tested. That high positivity rate tells us the true case count is almost certainly larger. Now, why does this matter beyond Central Africa? The 2 confirmed cases in Kampala are the key signal. Kampala is Uganda's capital, a major regional and international hub. The 2 cases had no apparent link to each other, which suggests independent introduction events, not a single chain of transmission. Ituri province borders Uganda and South Sudan. The WHO has identified all countries sharing land borders with DRC as being at elevated risk. And there is one more factor worth understanding. This outbreak was detected in the same region, Ituri province, where the second largest Ebola outbreak in history occurred. That outbreak lasted nearly 2 years. The infrastructure for response in this region has been repeatedly stressed. The ongoing security situation limits access. These are not favorable conditions for rapid containment. For healthcare professionals, particularly those working in or receiving patients from affected regions, here are the practical points. Ebola spreads through direct contact with the bodily fluids of an infected or deceased person. It does not spread through the air. Standard transmission-based precautions, contact and droplet, are the foundation of protection, along with full personal protective equipment, including face shield, double gloves, gown, and boot covers for any direct patient contact. The incubation period for Bundibugyo Ebola is 2 to 21 days. Any patient presenting with fever, unexplained hemorrhage, vomiting, or diarrhea who has traveled to DRC, Uganda, or neighboring countries in the past 21 days should be assessed immediately with full isolation precautions while investigation is underway. Early recognition is everything. I want to say something directly to the public because Ebola generates fear, and fear is not always proportional to actual risk. If you have not traveled to DRC, Uganda, or neighboring countries, and you have not been in contact with someone who has, your personal risk is extremely low. The WHO has specifically advised against border closures and travel restrictions because these measures cause more harm than they prevent. What actually stops Ebola is contact tracing, isolation of cases, strong IPC in healthcare facilities, and community engagement. Not panic, not stigma, and not border closures. The DRC has faced 17 Ebola outbreaks since 1976. The country has experience, expertise, and resilience. International support from WHO, Africa CDC, MSF, and partner countries is already being mobilized. Stay informed. Trust verified sources. Trust verified sources, WHO, CDC, Africa CDC, and if you are a healthcare professional, review your Ebola protocols today, not tomorrow. This outbreak is a reminder of something that never changes in infectious disease medicine. The pathogens that concern us most are not always the ones making headlines. They are often the rare ones, the ones we have less experience with, fewer tools against, and less institutional memory for. Bundibugyo Ebola has now caused the largest outbreak of its kind in recorded history. It emerged silently, spread in a conflict zone, reached a capital city, and triggered a global health emergency, all within 3 weeks of its first known case. At No Infection Consulting and Education, we will continue to monitor this situation and publish updates as they develop. Visit us at noinfection.com. I'm Dr. Fabíola Tiburcio. Stay informed, stay prepared, stay infection-free.